Hello, everyone. In previous sessions, we provided a general introduction to the concepts and research of the social determinants of health. Then we spent some time asking ethical questions about health disparities. After that, we looked very closely at Madison Powers and Ruth Fadden's approach to social justice and situated their framework within the larger tradition of political liberalism. Today, we return to social determinants in order to focus on the issue of class or socioeconomic status. So let's get started. So class is without a doubt the strongest predictor of health, disease, and longevity. There are, of course, other determinants of a person's health, such as age and gender. However, class remains one of the most powerful social determinants of health relative to other variables. So just take an example. Elderly diet. As the elderly age, they often adjust their diet. However, for those who belong to higher social classes, they often make positive changes, whereas those who belong to lower classes are more likely to make negative changes. And this pattern is consistent across a broad variety of other variables. So at the same time, though, class is more complicated than we often assume, right? It has to do with more than just being economically rich or poor, as we will see. So let's take a closer look. A great example of how class and health goes hand in hand is to take the metro system in Washington, D.C., from the southeast to Montgomery County. According to Cockerham, for every mile traveled, life expectancy for the residents rises approximately 1.5 years, amounting to a 20-year gap between the lower income blacks versus wealthy whites. So what is social class then? Well, it is a category of people who have approximately the same amount of wealth, status, and power in our society. So what makes social class today distinct from classes in the past, in historical periods, is indeed the transition from the medieval agrarian types of economies in the West to industrialized economies, which is defined by large urban centers during and after the Industrial Revolution. And that happened around the 19th century. So nowadays, wealth, rather than land, has become the dominant form of economic power. And subsistence-based systems of economic life, those still exist today, really have given way to a more commodity-based market economy. So class divisions are thus no longer based on family, kinship, or royal lines, for instance. But neither is it just as straightforward as the division, say, between wealthy industrialists versus the workers, right? So to jump a little bit ahead, between the 1950s and 1970s, both education and wealth are evenly distributed. That era is often referred to as the Great Compression, right? Today, however, divisions in education levels and wealth have increased. And so studying the effects of class on health has never really been more relevant, precisely because class takes on a slightly different meaning than it has before, historically speaking. So in medical sociology and epidemiology, we have a fivefold division of classes. So you have the upper class, the upper middle class, lower middle class, the working class, and then the lower class. So again, wealth and income are important factors of your class position, but they are not the only factors. As German sociologist Max Weber points out, there are also other factors that are relevant, subjective and cultural elements, for instance, to social class, such as your social prestige, your social hierarchy, your position within the social hierarchy, how much respect do you have, as well as lifestyle choices, things that you buy, things that you wear. And this means that people who belong to the same social class often also share similar behaviors, norms, and customs. Today, the concept of socioeconomic status, or SES, takes into account income, social prestige, education. So income is what is usually associated with class, but occupation in this model also matters because it provides prestige, respect, as well as social influence. And we can also add access to technical knowledge. And lastly, you can see how education is intimately also connected to the other two elements of socioeconomic status. For instance, many research suggests that education is perhaps in today's economy one of the best predictors of health and longevity. So a 2005 study showed that in 1960, life expectancy at 35 is extended by as much as about 1.7 years by only 1 extra year of education. And subsequent studies only confirmed the relationship between education and longevity. This is not surprising, right? Because education provides many things that could grant us longevity, such as critical thinking skills, a social network of competent people, right? The ability to acquire medical knowledge, right? And the probability that new kinds of medical technology would be used. But education also provides other things, such as economic stability, right? Economic mobility, a meaningful career, a higher paying job, right? More respect from peers, and the ability to advocate for yourselves, right? To organize, to know how to advocate for yourself when issues emerge because of your education. And so being educated means you also have a little bit more control over your life's circumstances, your work environment, as well as your community. And all of these things together factor into what we called before self-determination and relational autonomy, right? However, education attainment today continues to track alongside class lines. This means that highly educated parents produce highly educated children, and reverse is also the case. And today it's reached a point where the academic gap between people who are wealthy versus people who are poor now exceeds the gap between that of white and black students in the 1950s. So even though the expansion of access to education has drastically improved health in general, the disparities of education and thus the disparities of health continue to stay with us. So let's take a look at this table. It clearly shows that people with less than 12 years of education, that means less than high school, have the highest death rate. You will also see that even though life expectancy is increasing, right, the life mortality rate disparity between the highly educated and the less educated also increased. Do you have any theories as to why that is? So let me provide you with some historical context. Those who were born at the end of World War II saw their opportunities really expand, their income doubling basically between 1940s and 1960s. Children were also very likely to exceed their parents in terms of their earning power in the United States during that period. So to give you an example, unionized workers in Detroit for one of the big three automakers could make anywhere from $40,000 a year to $100,000 a year without more than a high school education. Nowadays, to make that much money, you would at least need a college education, if not more. But since the 1970s, the income of the top 1% has tripled, while the median or real income of middle class people have really increased only by a tenth. And since the year 2000, the median income did not really increase at all for middle class people. So the middle class is in a lot of ways then in our time blocked from income, power, and prestige, right? While the meritocratic system that we have now makes education essential for income and social status, it really hasn't worked out very well for working class people because they have experienced significant stagnation. So when middle class jobs are being destroyed and because they're dwindling, it also leads to a lot of their marriages falling apart, and their mortality rate, especially of white working men, also increased. as the whole communities, are forced into a kind of survival mode in our economy. So there's a sort of unprecedented rise of mortality apart from wars in the United States that are caused by depression and disease. All the while, the middle class is primarily becoming consumers because their labor opportunities continue to dwindle due to a variety of factors, including the technological advances. So we can see that suicides, overdose, as well as alcohol abuse increased about 3 to 5 times faster among less educated adults in the United States, and now kill Americans at a rate roughly equivalent to the AIDS pandemic not too long ago. So Michael Marmot and others have provided some of the best evidence showing the connection between class and health in what is now called the Whitehall study. So they study about 18,000 British government employees and their mortality rates. And these employees were divided into a hierarchy of 5 classes, all the way from senior administrators to professionals, executive, clerical workers, and then others. They were all between the ages 40 and 65 when they're interviewed in the 1960s. And so the researchers returned 10 years later in order to collect data on the mortality rate. And the data actually showed that no matter what the cause of death is, people with the highest rank have the lowest percentage of deaths. On the other hand, people with the lowest occupations, lowest ranking occupations, have the highest death rate. Now, this study surprised the researchers. What do you think were the reasons for this surprise? So the researchers assumed that civil servants would live longer than the general population, regardless of their rank, because number one, they all have government's job, and government's jobs are usually stable, right? Government jobs were also free from workplace hazards, right? Like unlike, say, in a dangerous factory, for instance. And government jobs are also mostly middle-class jobs. So they have a little bit of social prestige attached to them. And then number 4, all have free access to healthcare, right? As they have the national health insurance. And then number 5 is that no one is really in poverty, right? Nobody lives below the poverty line. And it shows that health disparities can emerge not because of the existence of absolute poverty, but they can emerge out of social hierarchies. So this social gradient, as they come to call it, is consistent with the general population as well. People who are usually higher on the social hierarchy, those who have a higher socioeconomic status, live longer than the people who are just below them. This is a very interesting phenomenon, which is also studied in terms of other areas. For instance, in a study of 2012, researchers have studied social hierarchy's influence on physiology in rhesus monkeys. Now, the results show that gene activity that regulates the immune system is different depending on the monkey's social rank within the group, to the point that the blood samples can predict social rank at about 80% certainty. So health is thus causally related to social and the physical environment that one is exposed to on the basis of social rank. And this influence of social rank over health outweighs the differences between individuals. Some of these environmental determinants are things like self-esteem, status differences, self-direction in work, and control over one's environment. Social capital, as well as having access to social support network. Now, all of these things decline as one moves down the socioeconomic status. Again, social rank or socioeconomic status is not simply about material prosperity. For instance, Okinawa has one of the highest life expectancy in Japan, and yet it has one of the lowest income, relatively speaking, although the people in Okinawa are not poor. This is because Okinawa is not an urban center, and its population has a very different cultural structure. They have a very close-knit family structure with a very unique food culture. So cultural and social factors also determine health. Although social gradient holds still, the social gradient of health based on socioeconomic status still holds in most places within the modern economy. So we have said at the outset that healthcare and healthcare delivery only accounts for about 20% of public health. This means that although healthcare is important, it is not what is solely responsible for good or bad health. Now, the British NHS was created in the 1940s in order to make healthcare free for everyone. It was thought that class differences would then be eliminated because everyone would have access to healthcare. But according to the Black Report of 1980, it proved otherwise. It showed that although health has generally improved, it does have an effect, right? Having access to healthcare does improve the health of the general population. The health gap, though, between the upper and lower classes has only since then widened. As we will see, healthcare alone does not ensure that lower class people do not bear the brunt of the burden of the conditions of bad health, such as a polluted environment, poor housing, and bad work environment, and lack of education. People who are lower on the socioeconomic status also are less likely to seek preventive care. So the bulk of healthcare still then went to treatment and interventions instead of preventive care, which is more expensive. Another important finding showed that such disparities are worse for children who have poor health because their upward mobility is permanently compromised. So let's take a look at a few examples of how socioeconomic status affects health. One of the things to keep in mind is that this pattern, this gap between those who are on the higher class versus those who are lower class, is reproduced in the United States as well. After the passage of Medicare and Medicaid in 1965. So even with improved access to healthcare, lower class Americans continue to struggle with a lack of treatment facilities, understaffed and overcrowded facilities, as well as underfunded public hospitals, and a lack of transportation, which leads to lack of preventive care and relatively poor health outcome. So let's take a look at how socioeconomic status affects health. So let's take a look at the behavior and psychological consequences of low socioeconomic status. And one important concept to take note of is this idea of time preference. So to take education as an example, in order to get an education, one must be willing to postpone the payoff for one's investment of time and effort, right? You have to postpone doing something that you would like to do that would give you some economic benefit, like taking a full-time job. Similarly, to take seriously the warnings of the dangerous health outcome caused by something like cigarette smoking, one must also have a clear perception that it is worthwhile to forego the immediate satisfaction that can be gained with smoking, right? In order to avoid the bad health consequences that will likely appear sometime down the road, if not decades. So time preference is very important to remember because our decisions are influenced by how we value our time differently. So let's take a look at some models of how we value time. So our time preference is dependent on our time perspective. So let's take a look at three different time perspectives. The first one is future. Those who are future oriented, right? They're characterized by planning as well as the achievement of future goals. They're all about what I can do in the future. I'm going to plan. I'm going to make sure what I do is going to be oriented towards the achievement of those goals. However, for those who are more present oriented, first of all, for fatalistic reasons, they reveal a belief that the future is predestined and is uninfluenced by their individual actions. And so the present must be born with resignation because humans are at the whimsical mercy of fate. So people who experience fatalism adopt the perspective of present orientation because they are less likely to put much stock on the future. Another version of present orientation is for hedonistic reasons. Their orientation is towards present enjoyment, pleasures, and excitements, without wanting to sacrifice today for future rewards, as well as a lack of consideration for future consequences of present actions. Now, all of these things are very much related to our social environment as well as our socioeconomic status. If your life circumstances does not give you much hope about your future, you might decide that it is more important to enjoy the simple pleasures of the present, such as getting married early or having kids early, rather than trying to work on attaining educational achievements. So it's not surprising future orientation is correlated with educational attainment and success. And while fatalism is associated with poor performance and aggression sometimes. So we have seen that how low socioeconomic status exposes people to a different environment. And that environment in turn impacts how they view reality as well as their own agency. So you can either have a future orientation or you can have a present orientation, sometimes for fatalistic or hedonistic reasons. So another important behavioral factor to keep in mind when talking about socioeconomic status is self-efficiency. Now we know that based on differences in a person's childhood experience, either because of family dynamics or the environment in which they grew up, people can develop strikingly different perceptions about their own ability to direct their own lives and to make a difference. So this leads to some people believing in their abilities and agency, while others fail to believe in themselves and their ability to change their circumstances. So as you can probably guess, those who have a higher view of their own abilities and chances, or those who perceive themselves as having options in life, are more likely to pursue long-term plans and goals than those who don't see themselves as having options. So our social circumstances can also drastically influence our self-perception in terms of self-efficiency. Social enemy and the loss of trust in society is another big factor, right? If a person's experience tells her that society does not really treat her fairly, either because she belongs to a particular marginalized social group for various reasons, and does not respond to her needs, then that person is likely to lose faith in the norms of society and begins to feel alienated and isolated. So people who experience social enemy are also less likely to adhere to norms that lead others in the same society to healthier outcomes. So this chart shows how socioeconomic status can lead down the road to bad health outcomes. It's pretty self-explanatory. You begin with social structures, and then how the environment within which you would live because of those structures and your position within the social hierarchy can then lead to physiological and behavioral changes, which can lead to bad health outcome. While it is important to talk about relative inequality in terms of differences in socioeconomic status, it is also important to talk about poverty, because poverty makes a huge impact on people's health as well. In 2018, about 38.1 million people were in poverty. About 17% of those were children, about 12.8 million. But this is a little deceptive because about 28.4 million children, which is 40% of the children, live just above the poverty line in the United States. So it is important to look at how poverty creates a chain of causes that leads to people developing bad outcomes later on. One of the most important factors to consider when talking about poverty is the effect of neighborhoods. In the United States, neighborhoods are usually economically homogeneous. That is to say, people who share the same socioeconomic status usually live together. So this means that people who are in poverty, poor people also then live together, which then multiply the negative impacts of environmental determinants of health. They are then exposed to poor housing, toxic chemicals like lead and molds. And we can see this is also problematic because for many years the lead industry refused to acknowledge that lead is bad for people, right? Especially toxic for developing children who can suffer from cognitive defects because of that. They also suffer from discriminatory practices because of them being in a position of vulnerability. They also often are living in very crowded spaces, right, where there's a lack of privacy as well as an increase in relational stressors. This is why there's also an increase of domestic violence, right? In addition to being exposed to an environment where there's a higher chance of street violence, higher encounters with illegal drugs and vandalism and things like that. It is also important to note that noise and environmental pollutants are also significantly associated with poor neighborhoods, because dirty industries and sewage plants and factories and highways run through poor neighborhoods, partly because there's no way that they can defend themselves from these industries and practices. Noise is a huge issue as it increases stress. And they also experience more regular evictions and homelessness. And the children go to seriously underfunded schools, which lead to diminished future. So all of these things have a worse impact on children who are in poverty, because it compromises not only their general health and their cognitive abilities, but it leads to the reproduction of poverty in their adulthood, right? As we know, one of the examples that toxins can affect children before they're born. And when children develop cognitive issues later on, it also diminishes their chances of, say, getting a better education and then eventually raising their socioeconomic status. And people who live in poor neighborhoods also lack access to, say, neighbors who have resources, right? People who can help you out when you're in need of help. They also lack access to neighbors who are educated. Then again, this is related to having access to competent skills and resources when you need it. And they also have lack of access to nutritious food options and transportation, which is needed for both education and to get good groceries. And they also lack meaningful and adequately paying jobs, which then is related to chronic poverty and homelessness. And as a result of lacking all of these things, they also then lack resources to advocate for themselves in their own communities, leading to more dirty industries, for instance, coming into the community. So all of these factors combined can create a cascading effect on the health of people who live in impoverished conditions. As we talked about in a previous session, these are called cascading effects, right? Where multiple social determinants come together to worsen the health outcome. So stress is a very significant factor that is associated with low socioeconomic status. So what is stress? Well, stress is a heightened body-mind reaction to stimuli that induces fear and anxiety in the individual. And it originates in situations where people find it threatening or burdensome. The prolonged exposure to stress can eventually wear down the body's defenses against disease over time and make people a lot more susceptible to becoming sick or to act directly on the body's organic system, causing physiological damage in itself. So in other words, stress increases what is called allostatic load, right? Which is the wear and tear of the human body that affects our neurochemistry, our cardiovascular system in a very negative way. So life events, significant life events such as the loss of job, chronic strain such as prolonged poverty, or daily hassles such as traffic or waiting in long lines, can all be very common stressors for people who are experiencing poverty. So the lower one's socioeconomic status, the more life events, chronic strains, and daily hassle one also experiences. So stress is also a uniquely powerful predictor of health outcomes, because continuous and repeated stressors really do have a cumulative effect on our allostatic load. So things like unbroken poverty, victimization-induced anxiety, or experience of discrimination, lack of job opportunity, disrespect by social institutions, social rejection by others, and as well as lack of resources to deal with stressors, and then having to live in a crowded house, and then experiencing fatalistic to have a fatalistic view of reality, right? And all of these kind of have a cascading effect on someone who's poor, creating the conditions where stress becomes unmanageable. And also important to note that stress that is associated with socioeconomic status is not really easily prevented or even mitigated by individual behavior, right? Such as doing more mindfulness, because they're really a lot of these things are outside an individual's control. So they require to address these stressors require us to address these social causes of bad health outcomes. Another factor is income inequality. There is some evidence suggesting that income inequality is associated with disparities in health outcomes. However, the issue with this thesis is that income alone is merely one cause among many others for health disparities, as we have seen. So income inequality is not as strong a predictor when it comes to health outcomes as socioeconomic status, which takes into account more dimensions of class. And this is true especially for people who live in nations that have less economic inequality, such as Sweden, but they still continue to experience health disparities. Still, though, it is not hard to imagine how income inequality can, in fact, magnify differences in socioeconomic status. So culture is another important factor that is closely associated with socioeconomic status. One of the famous examples is the Russian gender mortality gap, which is at about 12.1 years. That is to say, Russian men lives about 12 plus years less than women, whereas that gap is only about 5 years in the United States. So there is thus a mortality crisis for Russian men. And research have shown that the primary cause of death is heart attack. So the secondary cause is really the lifestyle of heavy drinking. However, the ultimate cause behind it all is the disposition or the habitus of Russian working class culture, which includes the rules, expectations, and social practices that undergirds the drinking. So the real culprit is the Russian vodka culture, where the agricultural drinking culture was historically carried over into working class culture. So drinking has sort of become a social expectation and norm within this class. On a societal level, though, the difference between Russia and the United States is that the middle class did not emerge as it did in the United States. So that's why, as we've seen, that even though when people go up in the socioeconomic ladder, they also start drinking less, right? That didn't happen in Russia. Although national culture does permeate all classes, there is such a thing as a sort of national norm and culture. Still, each socioeconomic class have its own cultural practices and lifestyle choices, such that taste and preferences also track alongside class divisions. We have seen something similar about smoking and how it's related to socioeconomic status in the United States. So obesity is another example of disease that tracks alongside class lines. So studies suggest that eating patterns are shaped by group behavior, right? So the paradox for people who are living in poverty is that hunger and obesity can coexist within the same socioeconomic status groups, particularly among minority and women. Now, this is not surprising because low-cost foods are often also very energy dense, right? So though a lot of people lack essential nutrients, they can still take in a lot of calories that are really thin in terms of nutritional content. In addition, financial insecurity and economic hardship also tracks obesity. So we can see that, as we have seen before, stress can lead to problems in terms of growth hormones, in terms of reducing the growth hormones that can reduce fat and provokes craving for soothing foods, right? And then stress can also lead to other kinds of eating disorders, such as stress eating. And combine that with lack of access to healthy foods and the lack of family meals, for instance, and a lack of a safe environment for outdoor activity, then you have a recipe for obesity. So it is thus not surprising, right, that medical sociologists and epidemiology sees socioeconomic status as a fundamental cause. And we have seen before, a fundamental cause has to fit three criteria. Number one, it has to influence multiple diseases, which it does, right? It has to influence these diseases through multiple pathways. and then these pathways are then reproduced over time, and they have to also involve access to resources that can be used to avoid the same risk, or at least to minimize the consequences should these risks occur. So this is why socioeconomic status is a fundamental cause that we have seen during this session. So hopefully this session has introduced you to some fundamental ideas about how socioeconomic class or socioeconomic status relates to health outcomes.